Good afternoon. Thank you, organizers, and especially Dr. Bansi Sabu, and thank you, Chairperson, and thank you, my dear friends and delegates who are present inside the hall. Well, my topic is the deadly dozen or the dirty dozen and the sweet 16. We all know only about the ominous octet, but the difference was ominous octet, which took a lot of time from the triumvirate to ominous octet, but within few years, it will now become probably sweet 16 and even beyond that. Let us look into that briefly. Well, from where the word dirty dozen came from, it's a very famous Hollywood movie. It was a massive commercial success. It was about a very famous D-Day approach. Major Risman must train a team of soldiers to parachute across enemy lines and kill German personnel in the World War II. And based upon that, this movie was filmed, and it met with a huge success. And from that, the dirty dozen word became popular. In the field of diabetes, there are a dozen etiologies through which blood sugars can increase. So we'll just discuss about that. While I was reading that, I just found that right from as the wheels of the vehicle which you are using has progressed from this to this towards the highly technological airplane wheels. Similarly, in diabetes also, the progress has been relentless. If you look at the natural history of diabetes, it was initially for years just triumvirate, that means insulin resistance in muscle and liver, and beta cell failure. This was we were knowing about the causative mechanism for diabetes. From there on, it became disharmonious octet with the fourth member, that is fat cell, identified, and for that pioglitazone was the responsible drug which worked on that. From that, the incretin effect thereafter was identified, and the gut factor became very popular, and it became the fifth member. From there on, pancreatic alpha cell, on which GLP-1 analogs as well as DPP-4 inhibitors also work, was identified to have effect in causation of hyperglycemia, and its modification may control the blood sugar, that was identified. So it became cetaceous sextate. The seventh member, kidney, it was identified long back, but there was no therapy available for that. Once the therapy in the form of SGLT2 became available, it became septicidal septate. And the brain satiety center, with the invention of the GLP-1 analogs, it was identified that brain also plays an important role in controlling the satiety. The ventromedial nuclei, the paraventricular nuclei in the hypothalamus are the key centers for appetite regulation. And if you control them, probably you may be able to control diabetes in a better way, and not only control diabetes, also reduce the weight of our diabetic patients. So from triumvirate triacetate, it became ominous octet. So at present we know till about the ominous octet. But what next? And at present we have multiple drugs that work on this ominous octet. So now from ominous octet to dirty dozen, but while I was preparing, I found that not dozen, there are more than 16 members in this family which are responsible for causing blood sugar. 8 of them are well understood, explained under ominous octet, and 8 yet to be understood totally. So total it makes 16. Let us look at number 9, because up to number 8 we know. So I will not go into details about those. We will start with number 9, that is dopamine. Well, we know something about that mammalians have the ability to alter their metabolism from insulin sensitive glucose tolerant state to insulin resistant glucose intolerant state at exactly the right time of the year to survive long periods when food is scarce. And at the end of the season, animals revert back to their insulin sensitive glucose tolerant state. The dopaminergic and serotonergic rhythms in the suprachiasmatic nuclei and ventromedial hypothalamus play an important role in transition from insulin sensitive to insulin resistant state. How do this work? Well, serotonin and noradrenergic levels and activity are increased during the insulin resistant state and decreased to normal with return to the insulin sensitive state. Conversely, dopamine levels are low during insulin resistant state and increase to normal following the return to the insulin sensitive state. So higher the dopamine levels, better will be the response as far as the blood glucose is concerned. So selective destruction of dopaminergic neurons in SCN causes severe insulin resistance. This is well known. how to modify it with treatment? Well, we now have dopamine receptor agonist bromocriptine. In the health, what happens in the early morning in diabetic people? There is hypothalamic decrease in the dopamine levels in diabetic people and elevated noradrenergic and serotonergic levels, which leads to increased hypothalamic SNS activity, increased hepatic glucose output, increased lipolysis, free fatty acids, increased lipogenesis and increased triglycerides. All this lead to metabolic syndrome as well as hyperglycemia. If you give a D2 receptor agonist, bromocriptine, what will happen? There will be increased morning hypothalamic dopamine levels, and which will have positive influence on all this, reducing the chances of diabetes, or in the therapy of diabetes it can be used. What are the studies? Well, the monotherapy studies add on to the other OHAs. D2 agonists like bromocriptine have been shown to reduce the HbA1c by about 0.5 to 0.6%, in some studies even up to 0.9%. And very importantly, these are the only drugs or the first drugs to be approved by US FDA in reducing the cardiovascular safety. So, they are cardiovascular friendly drugs. Only thing, the data of the Parkinson patient was used for the cardiovascular approval, but otherwise they are cardiovascular friendly drugs, not as effective as the other drugs may be, but a modest reduction of HbA1c in the tune of 0.5%. Let us go up to number 10, that is vitamin D. We all know vitamin D has multiple roles, but till now nothing is absolutely proven. But in diabetes, there are number of reasons by which vitamin D may have an effect on the glucose metabolism. It is not a hormone, it is a prohormone. It is produced in the skin from cholesterol, and calcitriol is the active hormone. All the organs use vitamin D by 1-alpha hydroxylation of calcitriol. By various ways, vitamin D can influence the glucose metabolism. I will not go into details of this, you all know this. Vitamin D has direct as well as indirect effect on the glucose. It stimulates the expression of insulin receptor, it activates the PPAR gamma and PPAR delta, it regulates the extracellular calcium flux through the cells, it has anti-apoptotic effect by modulating interaction of NKF beta and effects of cytokines, and it also has effect on RAAS, and through this also it may have indirect action in the glucose metabolism. Whether the treatment with vitamin D helps or not? Well, there are several studies, not a big trial, but several studies or the retrospective analysis from studies have shown that vitamin D has positive effect on insulin secretion as well as insulin resistance. These are few studies published in American Journal of Nutrition or International Journal of Clinical Practice, which have shown that treatment with vitamin D of 1000 to 2000 units reduces the blood glucose by about 20 to 30 milligram per cent deciliter and HbA1c by about 0.5 to 0.6%. So, there are several studies which have shown vitamin D has effect on insulin sensitivity as well as insulin resistance. Especially in women who are supplemented with vitamin D also have beneficial effect on CRP and also have beneficial effects on blood pressure. This needs to be proven, but yes, vitamin D is a factor which is responsible for causation as well as the therapy of diabetes. Let us come to RAAS, and here I am not talking about RAAS of kidney, I am talking about RAAS in the pancreas. Well, amongst 50% of hypertensive individuals have hyperinsulinemia or glucose intolerance, whereas up to 80% of type 2 diabetic patients have hypertension. So, there is a close relationship between diabetes, hypertension and RAAS activity. Trials predominantly using either ACE inhibitors or ARBs have reported a reduction in new onset diabetes ranging from 15 to 35%. So, what is the mechanism? The mechanism is RAAS and angiotensin 2 will lead to adipocyte differentiation, which will reduce the adiponectin levels, increase the inflammatory cytokines, which leads to insulin resistance, which leads to diabetes. It also has insulin signaling pathway effect, through which it reduces GLUT4 and reduces glucose disposal, which will lead to insulin resistance and diabetes. Also has effect on free radicals and nitric oxide, which reduces the blood flow in the skeletal muscle, which will lead to insulin resistance, less glucose disposal, diabetes. It also leads to endothelial dysfunction, The free radicals also lead to beta cell dysfunction, which again causes diabetes. So, various mechanisms through beta cell dysfunction or through insulin resistance, RAAS activation can cause diabetes. What is the treatment? We know that from meta-analysis of 13 randomized trials of more than 92,000 patients, either treated with ACE or ARB, new onset diabetes was prevented in about 33% people. RAAS inhibition reduced the incidence of diabetes by 33%. So, that is a huge number. If you can reduce diabetes by using a drug like RAAS or ACE or ARB, it is a great achievement. So, RAAS inhibition either with ACE or ARB contributes to the prevention of diabetes. Next is testosterone. Well, after the age of 30, the average annual decline in testosterone is about 1 to 2%, and hypogonadal men with BMI of 25 have threefold higher prevalence of metabolic syndrome. So, there is a great interplay between diabetes, obesity and hypogonadism. There is high degree of overlap between this. If you look at this graph, at this table, people with lowest tertile of testosterone and with middle tertile have higher risk of developing diabetes and metabolic syndrome, whereas in the highest tertile, the risk of developing diabetes is lower. You can see from this slide also, if testosterone level is less than 280, 90% of these people develop metabolic syndrome. If the level is normal, only about 30% develop metabolic syndrome, which means testosterone deficiency is also responsible for causation of diabetes. The mechanism, it reduces lipoprotein lipase activity and associated uptake of triglycerides into visceral adipose cells, thereby reducing the size of these highly insulin sensitive cells. Testosterone is an anabolic hormone that helps to increase the lean muscle mass and is also known to improve insulin sensitivity. So, there are some insulin sensitivity issues which are improved by testosterone, and that is why its deficiency can cause diabetes. How can you treat that? Well, Times 2 study, it was a large multi-center European study, randomized double control, placebo control. It demonstrated that testosterone replacement with 2% gel in hypogonadal men improved insulin resistance at 6 and 12 months by 15 to 16% compared with placebo. Times 2 also showed significant benefit on insulin resistance similar to that reported with metformin. So, it is as effective as metformin probably in reducing the insulin resistance in hypogonadal men. IM injections of testosterone that is given once monthly or once fortnightly are also effective in reducing the HbA1c and insulin resistance. A1c reduction of about 0.37, which is minor, but still it is observed with testosterone therapy. Only thing or the only concern about testosterone therapy is the safety. If you want to use testosterone, obviously you will have to use it with a 5-alpha reductase as adjunctive therapy, otherwise it may increase the risk of prostate cancer. Coming on to number 13, that is melatonin. Well, melatonin is a nutraceutical product marketed in US for so many years. The production and secretion of melatonin by pineal gland follows a diurnal pattern, peaking 3 to 5 hours after darkness and declining sharply prior to awakening. For melatonin, pineal gland is responsible, which identifies whether this is daytime period or nighttime period, and depending upon that it will stimulate the sleep receptors. If this sleep rhythm is disturbed, it is associated with decreased melatonin secretion. The sleep disturbance confounds with the association of melatonin and diabetes, and lower nocturnal melatonin secretion is associated with insulin resistance. Non-diabetic men who reported sleeping less than 5 hours, probably our Prime Minister also, were twice as likely to develop diabetes as those who reported sleeping 7 hours per night. And night owls were 1.7 times more likely to have diabetes and metabolic syndrome than early risers. We know the story of the people who work in the call centers. They are also at a higher risk of developing diabetes, probably due to this reason. How do we treat? Well, melatonin therapy in diabetes is considered nutraceutical by FDA, and studies have shown that it can reduce the insulin level, triglyceride, insulin sensitivity index significantly as compared to non-supplementation. So melatonin also is an important factor while considering the therapy in diabetes. Thyroid. Both hypothyroidism and hyperthyroidism are associated with insulin resistance and some problem in the beta cell function. You can see that thyroid also has effect on total cholesterol, LDL, triglyceride and HDL. It also has effect on HOMA insulin resistance, insulin sensitivity. How do we treat? Restoration of euthyroid state, whether patient is hypothyroid or hyperthyroid, helps reducing the insulin resistance and also improves the beta cell function. So that is the basic treatment, correction of the thyroid status, either with levothyroxine or if patient is hyperthyroid with neomercazole. Kidney. Well, kidney has been very well identified for glycosuria, but kidney also produces significant amount of glucose, which is called renal gluconeogenesis. In health, this function is only about 20 to 30%. But when the hepatic neoglucogenesis is inhibited by the other agents, there are studies which have shown that kidneys can compensate that by producing more glucose. And this is responsible for this renal medulla is responsible more than cortex. The studies have shown that as liver becomes dysfunctional or if you inhibit the gluconeogenesis from liver, kidney will compensate that, and this is seen classically in patients who undergo liver transplantation. When the liver is removed during transplantation, still the blood glucose does not fall, still the endogenous glucose release does not fall because the kidneys can compensate that. So there are studies which have shown that kidney is an important organ which is responsible for glucose production. Importantly, liver produces glucose only in the fasting state, whereas kidneys can continue producing glucose even in the post-absorptive state. There are studies to show that, and there are graphs to show that. Because of paucity of time, I will not go into details of this. The only drug that has been identified for reducing the renal neoglucogenesis is Dr. Panikkar's favorite pioglitazone. It significantly reduces the amount of renal neoglucogenesis precursors, and as it reduces insulin resistance, it also reduces sympathetic activity. Finally, gastrin. Well, gastrin plays an important role in pancreatic growth and development in fetal life, all of us know. The pancreatic gastrin expression is suppressed after birth and then found as a growth factor in gastric antrum and duodenum after fetal development. Excessive gastrin has been associated with new islet and beta cell formation, and gastrin hypersecretion results in formation of new islets containing new pools of beta cells. Patients with ZE syndrome have new islets and increased beta cell replication. They may have insulinoma also. So association of gastrin and beta cell function or beta cell synthesis is very well known. How does it work? Gastrin transfers the pancreatic ducts into the islets. You can see from this slide that this gastrin is responsible for production of new beta cells in the pancreas. How do we treat? At present, we have PPIs available which improve the gastrin level, and many studies have shown, the double-blind placebo control studies have shown that PPIs, including rabeprazole or pantoprazole or omeprazole, whichever you are using. These studies are with pantoprazole. It has shown that HbA1c reduction from 7.5 to 6.6 as compared to 7.8 versus 7.4 in the placebo group. The first phase insulin secretion, late phase insulin secretion, total insulin secretion, all are positively influenced by the PPIs. There are various studies, including this 12-week trial with 31 patients, 38% rise in gastrin, 1.2% HbA1c reduction from 7.9 to 6.8 in the PPI group versus the placebo group where there was increase in the HbA1c. This was published by P.K. Singh and colleagues in Journal of Clinical Endocrinal Metabolism. A very latest study from PPI came this year, which also showed that PPIs reduced the HbA1c by about 1%, and that was seen in patients who were taking insulin or on multiple oral agents. So there are several studies, I will not go into details about the PPIs also. So this completes the list of 16. So deadly dozen we were going to talk about, but it has ultimately become 16. These are the dozen, and we just discussed what are the other 4. So total it makes 16. So well understood 8, just I described 8. So total 16 pathways to make sugar sweet. So that's why it makes 16 ways to make sugar sweet, that is sweet 16. But while studying, I missed out iron. Iron is also responsible, excess of iron stored in the liver is responsible for insulin resistance as well as beta cell dysfunction. There are multiple mechanisms for that, especially in the beta cell. Iron is responsible for beta cell apoptosis causing diabetes. The treatment with iron overload reducers, but since this is not so common in our country, I have excluded from the list of sweet 16. Otherwise, this is also important. So, diabetes therapies addressing the sweet 16, we have already described about them. So, for each pathophysiology, there is a mechanism. So, I started in the Hollywood style with dirty dozen. I'm going to end with Bollywood style. Diabetes वालों को 17 तरफ से खतरा. Thank you so much.